And very welcome. I'd like to really thank you, your participation and your positive feedback and your positive answer to our call for being part of this parallel session. And we are really willing to have a kind of common understanding of how we can work better, how we can really go through all these situations that we are globally suffering. And we have heard from previous speakers how we need to really work together, how we need to collaborate together, and how we need to strengthen our health system. In our case, the main questions that I will just share with you, and I hope at the end of each of the participations we can have a kind of ideas of how to deal with this, is which are the lessons learned and what could be continued strengthening in the future. Why is this? Because I mean we know what can be the global responses to the COVID-19 pandemic, and I think what is important is how can we translate the global issues to the regional ones, and that's really how it should be, because it's at this local level, regional level, where we can really deal with the people that we know, and we know our priorities, we know our challenges, and I think that's really important. We are 6 people in this panel. As you know, I'm still waiting for Andre, because I don't want to take his part in the moderation. Let me check it. Sorry if he's. Okay. We don't have much time, so I really ask you to stick to the time that you are slot for. And okay, as since Andrea is not with us, I will go through our first panelist. It's from, sorry, I can't, if I pronounce any name wrong, please forgive me, but it's from Västra Götaland in Sweden. We have Ms. Salam Kaskas from the Regional Development Officer at the Department of Social Sustainability, and Ms. Tina Andersson, also from the Regional Development Officer at the Center for Equity in Healthcare. And they will share with us access to health services for the most vulnerable groups during COVID-19. The floor is yours, please.
Great, thank you, Sarah. Okay, let's just see, Salam, if you're able to. Great. Okay, now we see it properly.
Yeah.
Okay, great. You introduced us very well, Sarah. We're here today to tell you a bit about the efforts that we've been doing in our region, Västra Götaland, in Sweden, to enable vaccination against COVID-19 for vulnerable groups. So we're just going to say a few words about that. I think you can go to the next slide right away, Salam. And just to put a frame around this work, it might be important to say that the strategy in our region and also in Sweden at large regarding the vaccination has been to inform the public of why and how to get vaccinated, and then for the great majority, each individual have to make a decision, book an appointment, and go get vaccinated on their own. So it's very much up to the individual to get vaccinated. And from the start, we knew that this very general strategy wouldn't be enough to reach all individuals, all citizens in our region. Because we know that there are large differences, large inequalities in the population when it comes to access to healthcare in general, and we know that we will meet the same challenges also when it comes to vaccination. So very early on in our region, we initiated a wide collaboration with municipalities in our county, with different NGOs, and also with certain healthcare providers that have contact with vulnerable groups. And we discussed together what groups are hard to reach, will be hard to reach with an offer of vaccination in our region. What are the needs within the groups, and how can we make vaccination possible for these groups? We can go to the next slide. So the people that we have made certain efforts for, that we call vulnerable groups, are people that we rarely reach through our general activities, people who very seldom interact with the healthcare system, for example, because of lack of trust for the healthcare and for authorities at large, maybe lack of knowledge of both health and healthcare, also high thresholds within the system, and in this matter, lack of knowledge of rights to vaccination, both among vaccinators but also among citizens. And identified groups are, for example, people who are homeless, people who seek asylum or are newly arrived in Sweden. It could be sex workers or undocumented immigrants, hidden refugees, people with denied asylum, EU migrants. And I think if we go to the next slide.
Yes, so together with the municipalities and the NGOs, we have identified certain needs and necessities within the groups regarding both information, communication, and vaccination. So to identify what the group needed to get vaccinated, most and foremost was regarding specific information that responded to the situation for the groups. For example, information that you can get vaccinated regardless of your legal status, that if you had Swedish citizenship or not, social security number or not, but also information in different languages, of course. It was also important that the information about the vaccination reach the groups through channels that they are used to and from senders that they trusted. Tina mentioned that lack of trust was one of our identified obstacles. So this made us to collaborate with the meeting points, the NGOs, religious communities, radio channels in different languages, to go through to and send information through the trusted channels. Another thing that we identified was to make certain that there was flexible vaccination opportunities that have really low or no thresholds at all. I can show you. The next slide is like a general.
You need to finish, please.
Yeah.
Yes. This is a map of the efforts that we had to make to enable vaccination for vulnerable groups. So it was a lot of information, of course, externally, but also we identified that we had to do a lot of internal information to make sure that the care providers and the vaccinators also enabled really good information for the groups to get vaccinated. I think that we can stop here because we have the lack of time. We had some pictures only just to show you from the meeting points that we made certain vaccination opportunities for different groups. I don't know, Tina, if you want to.
No, I think we have to
yeah,
move on.
Sorry about that.
But thank you so much.
Thank you.
We'll stop here.
Thank you very much for this really interesting presentation. Sorry, I didn't mention before, I don't know if Andre is already with us. In any case, okay, please feel free to use the chat so you can comment, ask questions, and at the end of all the session, we will take those questions, comments, feedback, so please feel free of doing that. And let's move to our next speaker. I'm delighted to introduce Dr. Michele Tonon from the Department for Prevention of the Veneto region in Italy. And he will share with us the role of public health departments in creating networks against COVID-19. So please, the floor is yours. Thank you.
Oh, hello. I want to start thanking the organizers for this opportunity to participate into this moment of discussion and analysis. With this opportunity, I want to share our experience about the role of public health departments in creating networks against COVID-19. Veneto is a region in the northeast of Italy with a population of almost 5 million citizens. The regional authority has a role of control and management the health system, and which consists of 9 local health units. Each local health unit has a department of prevention, which is in charge for all public health activities. And in order to promote health in all policies approach, departments do not work on their own, but they constantly create networks and partnerships with other professionals, both in healthcare system as well as in other institutions like school, local administrations, and all other aspects of society. When SARS-CoV-2 began in its worldwide diffusion, one of the first Italian cases was recorded in our region. And starting on that night, on that Friday evening, all departments of the local health units were immediately alerted and put into actions. In fact, they are responsible for all the public health and activities and disease prevention and control and surveillance. Their existing experience in working with all different stakeholders of society proved crucial for achieving this goal. In fact, for example, after the first lockdown, when schools started to reopen face-to-face lessons, it was mandatory to put in place a strong contact tracing system specific for the school setting. Departments offered continuous support and guidelines for school managers. They were involved in monitoring and providing a response to suspect, probable and confirmed cases. And they provided particular and specific instructions for schools outbreaks in schools and kindergartens. All these activities were made possible thanks to the strengthening of the pre-existing networks for ordinary health promotion activities. Another example is with when the pandemic hit society hard, but the impact on the most vulnerable people was even stronger. So the lonely and the most socially vulnerable people, for example, requested constant support from the community during all these months. So during lockdowns or when more vulnerable people were forced to quarantine, public health departments strengthened synergies with municipalities, social services, and volunteer associations in order to grant home delivery of meals or to provide help or assistance. In addition to these activities, they also coordinated with the Civil Protection Department. The last example is the constant work done side by side with general practitioners. This partnership is essential for almost all public health promotion strategies and activities. So COVID pandemic highlighted this once again. For example, the sharing of COVID patients' data, vaccination status, and contact tracing showed how the exchange of information can facilitate the global management of citizens' health. In a pandemic emergency, this network got even stronger. So What we can conclude is that the pandemic experience led to a strengthening of the existing health systems and showed that dialogue between different actors is essential to overcome a complex and grievous event. As previously explained, this was necessary to reinforce the existing networks of preventions or even to create new ones in order to spread the message of promotion for a healthier society and to control COVID-19. The only approach possible was to overcome future challenges, is to fortify what was previously done, reinforce what has been done in this period of pandemic, and to imagine new approaches with the institutional and the other stakeholders. Thanks for this opportunity to share this experience.
Thank you very much. Very good example of public health strengthening into the whole system, and how you also use health promotion as part of that experience. We have...
Сара, меня слышно?
Can you hear me, Sarah? Sarah, can you hear me?
Sorry about these technical problems, Andre. Just for you to know that we went through the first and our second speaker, and if you would like to present our third speaker from Trentino, is that okay with you?
Да, спасибо, Сара. Прошу прощения.
Yes, right. Thank you, Sarah. I'm sorry for leaving you all by yourselves. Sorry for not being able to connect in time. I've run into some technical difficulties. And now I would like to present our next speaker, Dr. Piris Fatek Mokaddam. His presentation will be about... He will talk about vaccinations for marginalized groups, challenges and approaches.
Can you see my slides?
Yes, we can.
And okay.
Thank you.
Now, thank you very much indeed for the invitation to talk about vaccinations for marginalized groups, challenges and approaches as we encountered here in Trentino in northern Italy, 500,000 inhabitants, so a much tinier place than Veneto region we heard before. When I talk about marginalized groups, just very similar to what we heard from Vastia Götterland, I have in mind refugees, undocumented migrants, people without housing. Those groups have a greater risk of infection with SARS-CoV-2 because of housing conditions, collective shelters or overcrowded apartments, work conditions. We had several outbreaks of COVID-19 in the meat industry, waste management facilities, sorting centers for package delivery, and both of the above, because many of those workers in those industries, they live in crowded housing conditions. But not only greater risk of infection, those groups have also greater risk of not getting vaccinated because of reduced accessibility to health services, and at the same time they are hard to reach for health services because there's a language barrier, there are technological barriers as well, like no internet access or proficiency. There is vaccine hesitancy. This is an issue here in Italy. And in those groups, even more so. And health problems of the marginalized groups are not high on the political agenda. So in our specific situation here, to access the vaccination center, a pre-registration is required. But to register, the fiscal code or the health service membership card number is required. So under these conditions, newly arrived refugees, undocumented migrants, and people without housing are left behind, although health and vaccination services are guaranteed for every individual by the Italian constitution, regardless of his or her legal status. So our first proposal, I saw a very interesting Wasser Götaland as well. We wanted to have a mobile vaccination clinic at first, providing the information and Janssen single shot vaccine. But at the time, the mobile clinic was not available. Our local health ethics committee told us we had to guarantee access to all available vaccine, not just Janssen, and give information on possible additional risks of Janssen vaccine for people under 60 years of age. Keep in mind, in Italy, Janssen is recommended for people under 60, for above 60 years of age. So given these circumstances, this approach was considered not feasible, and we adopted another solution. A special form was developed and provided to all refugee centers, shelters, dormitories, soup kitchens, and to fill in this form, no documents were required whatsoever. And there was help of social workers to fill in, and then they delivered it by email to public health department. And we took care of the registration of the vaccinees and the access to the regular vaccination clinics and the drive-through here in Trento. We also provided information and Q&A sessions with professional interpreters when possible, and written material as well. But many times, written material is not so effective because there's a huge percentage in our refugees of illiterate persons held at centers, shelters, and in all these rollout of this campaign, the collaboration with an NGO, no-profit organization of health and social workers, which is called GRIZ, interested in migrant and health, was a key enabling factor. So this just some pictures of, this is the refugee center in Trento. Above you see a moment of information giving and registration for the vaccine of the refugees. And so currently we have 441 refugees hosted by the province of Trento. 72% of those have been vaccinated with at least one dose, 58% 2 doses, and 14% 1 dose as of the 18th of October 2021. Without housing, we don't have really, we have only just an estimate of how many people without housing are living here in Trento. We think about 200 people. Well, 175 were contacted and requested somehow the vaccination. 76% of those who requested the vaccination have been vaccinated with at least 1 dose. 56 2 doses, and 20% just 1 dose. So what are the challenges and what is the lesson learned here? We are the challenges we have to improve further the vaccination coverage. The rate is not bad, but it's not so much, but it's slightly under the mean rate for the Italian population. So we have to increment the vaccination coverage, to improve the compliance, to pay attention on the second dose. We want to send text messages to those who are risking to miss out the second dose. Another challenge are privacy issues, because to better promote the coverage and the compliance, the operators of the shelters, the centers, etc., would like to know the vaccination status and second doses and so on of their hosts, but we as public health are not authorized to share the individual data. So the lesson learned, or maybe it's better to say the confirmation of something we already knew, is that to guarantee the universal access to vaccination services and to, I would say, healthcare services as a whole cannot be achieved without outreach activities and special procedures addressing the specific needs of marginalized groups of the population. So thank you very much for your attention.
Thank you very much. I think this is also a good example of intersectoral work and how to engage with other sectors. As you mentioned, that you engage NGOs to work with the people, and this is really a good example of that. Thank you very much. I'd like to introduce Luigi Palestini from the Social Innovation Program from Emilia-Romagna Regional Agency for Health and Social Care in Italy. And he will be speaking about supporting equity governance in a regional health system during COVID. Luigi, please go ahead.
Hi, hello Sarah, hello everybody, and first of all let me say thank you for having us and for giving us such opportunity. I'll try to share a few slides, and could you please tell me if you see them? Are they on?
Yes.
Okay,
Yes.
good, perfect. Okay, so as Sarah was mentioning, our perspective is a bit different from what we saw before, because in the agency I work for is a local institution who works in order to how can I say, avoid fragmentation in organizational processes, and we try to foster the users and communities' participation in planning of social and health services. And basically what we try to do is try to implement the equity approach as a systemic approach in all our healthcare and social care services. So what I'm gonna tell you today is give you just a quick flash about what we did on the governance level for in striving for equity in our health and social care services. Just so you know, all our local health units have these three organizational devices which work for achieving equity in all our services. I'm not going to read all this because I'm going to leave you the slides at the end of my speech, but just so you know that every local health unit has a team and a representative that work on this topic. What we tried to do during the COVID pandemic is to use such occasion as a chance for organizational learning, because what we noticed is that on the other hand of dealing with the pandemic, what our local health unit did was to try and rethink themselves and introduce new ways of working. So what we asked ourselves was, how could we take advantage of this? So we tried to monitor the innovation and the emerging good practices, and we tried to understand what could be, saved and led to the upcoming years and built into the structure of our services. In order to do that, we started with a series of local workshops, exploratory workshops we had with our local health units and with the management of our local health units, and we tried to understand which issues were on the table since the pandemic started. And what we noticed, what we learned, is that basically there were no new issues, but there were older issues that were going stronger and stronger. And so the idea was for the next few years is to try and strengthen the proximity and continuity of care, and to introduce the idea of digital communication and telemedicine, and to focus on the users' needs, especially the users who rely on home care and chronic care services, because many of them had to deal with isolation, fear, and mental health issues during the pandemic. We noticed that we need to strengthen our function for proactive listening, not only addressed at users, but also at our healthcare workers, because also our workers had emerging vulnerabilities, and these vulnerabilities were complex and intersectional. And another thing that that emerged from this workshop was that we had to strive for the clearest communication possible, not just in order to avoid an inappropriate use of our services, but also because if we give visibility to what we do to create equity in our system, this leads to build, or I should better say, rebuild trust in our healthcare system. There are also another series of topics that we had to deal with because we just couldn't focus only on the emerging needs linked to the COVID-19 pandemic. During this year, 2021, and the upcoming years, we have an upcoming new regional prevention plan, which is going to deal with all the topics related to the public health system. We have to adopt and adapt to our local context the new national plan for gender-based medicine. We have an ongoing process of trying to implement good practices in terms of humanization and environmental wellness in our services. And we also have to plan some services on children's vulnerabilities using an instrument which is called EDI, the Early Development Instrument, which is a tool that can lead us to understand the vulnerabilities and inequities just from the start. I mean, when we are dealing with kids that are moving from the primary school to the elementary school. And in order to do that, what we did, and this is why I mentioned that we're working on a governance level, is to keep on working with a cycle of workshops with our local health units, because we need to share with the general management, and not only the general management, but also the district level management, the department management, to share and discuss the priorities that all our local health units were going to include in their equity action plan, because what I didn't mention before is that all our local health units have to have an equity action plan that has a duration of 3 years, and all of our local health units are going to plan and implement a new equity action plan for the next 3 years. We also had to understand with them and discuss with them what were some feasible and accountable interventions that had to be carried out from late 2021 onwards. And all this intervention and all this planning had also, of course, to integrate and keep into account also these topics which I just mentioned before. And we had a first round of workshops with our local health units in spring 2021, and we are holding now a second round of meetings with the general management and the department level management and the district level management of local health units. And in the upcoming few months, our local health units are going to get the new equity action plans ready. And what we achieved with them is that this is not just going to be some sort of groceries list of actions that have to be taken care in order to achieve equity, but it's a document, it's a plan that is going to understand and define which are the organizational steps and processes that are to be taken care of. And we also trying to keep the head and the hands of our local health units linked, because what we see is that we have a systemic approach to equity, which is defined and planned by the high-level management, and a low and practical and targeted approach, which is what our operative units do. But most of the time, there is some sort of void in between this, because we are not always sure that we have a strong link between between a systemic idea of equity and targeted approach to actions and to what we have to do. Yeah, sure.
Sorry for interrupting. We're running out of time.
Okay, I'm done, and that's it. I think I can end it right here, because I'm not. The other thing I was going to add was not really adding anything to the discussion. So thank you all for the attention, and if you have any questions, I'll be here until the end. Thank you.
Thank you very much. I remind you that you can ask questions in the chat, and I hope that at the end of the session we will have time for Q&A. And now allow me to give the floor to our next speaker. It is Clara Dokova from Varna, Bulgaria. She will also speak about working with vulnerable groups and minorities during COVID-19 pandemic, and she will also speak about collaboration with the non-state actors. Clara, you have the floor. Thank you very much, Andrei. Hello from Varna.
Thank you very much for that opportunity. COVID-19, like everywhere, posed and still is an enormous challenge for our region. Just a second, I want to share with you our small presentation. I hope that you can see it. Varna region is one of 28 regions in Bulgaria with a population of approximately 500,000 people, including 12 municipalities, and Varna being the biggest municipality with 350,000 people. Actually, during the COVID times, the main actors in our region were the Regional Health Inspectorate, the representative of the Ministry of Health on a regional level, responsible for the management and organization of all the activities related to COVID-19 epidemic. And of course, the Health and Social Directorates of the Varna municipality, working together with a wide network of healthcare providers on primary level, general practitioners, specialized outpatient care, and the hospital care, of course, supported by the Medical University and the University Hospital. And the efforts of our healthcare institutions were multiplied and strongly supported by a collaboration with more than 30 non-governmental agencies working in the area of vulnerable groups. The backbone of all the activities related to COVID-19 in our region are, of course, provided by the Healthcare Directorate and the Social and Wellbeing Directorate in the municipality of Varna that had to develop and offer specific COVID-related programs. Some of the most important and very active was the Mobile COVID Information and Vaccination Office, providing vaccination services for mostly disabled people, elderly people who could not leave their homes, and people living in institutions and also working in big institutions where they can be reached in an organized and much more easy way. They offered a very interesting, complex post-COVID follow-up and rehabilitation program for people with long-lasting COVID in a need of specific rehabilitation, and also a very successful program. 7 Roma health mediators are being employed by the Health Directorate of Varna municipality, who are people well recognized, well known by the Roma population of Varna, living in 4 distinct areas in our region. And their main role is to provide information to stimulate and to motivate for strictly following all personal hygiene measures, all social distancing measures, wearing masks, but also motivation and giving personal example for vaccination. So that's a very successful program. And
Kara, sorry, it's not about the time. It's because we can't see your slides. You are still in the first slide. So maybe you would like to share the other ones?
I'm really sorry. I don't know why this program appears. Excuse me, trying to... excuse me. Where's that? Can you see it now?
No, we can't.
Wait.
We could see the presentation, but we couldn't see it running.
No, you don't see the slide?
No, we can't see anything now. I would suggest maybe if you can keep, okay, here it is. If you can use the presentation mode, maybe it would be easy.
I will leave it here.
Yes, yes. Now we can see it. Thank you.
That will be the next slide. I just wanted to say that the Healthcare Directorate is working hand in hand with the Social and Wellbeing Directorate, which is actually providing integrated social and healthcare services at the home of vulnerable groups, especially disabled people and elderly people. One of the successful programs was the patronage care for disabled people, and warm lunch for people living under the poverty line. And as I mentioned, all these activities were multiplied by the collaboration with our NGO partners. And I have the pleasure to introduce to you Mrs. Magdalena Tsoneva, who is one of the experts working in the first NGO in Varna, a center for children with disabilities. Welcome, Magdalena.
Thank you. So hello from me. I'm representative of an NGO, Carindom Foundation, and we are partners with Varna Municipality and Varna Medical University. We serve around 300 children and their families, not only from Varna, but from the whole country. Children with disabilities, and we have therapy services, early intervention and training centers. So we train professionals and parents how to work and deal, how to support children with disabilities. So during the first wave of COVID-19, we had to be very quick to adapt our services from regular therapy services in the center to online, and I would say we had good success and innovations in this field, thanks to the fact that we work very closely with the families. So our consultations started to be entirely online. We have also parent support groups that we took online, and we digitalized all of our services, and also created a digital library that is in support for the staff. In regard to the families, we made additional efforts for parents' mental health, online consultations, so that parents know how to work with their children at home. And we also developed some videos and articles, stories, and made some...
Oh, sorry, but I need to stop you. Really sorry about that, because it's been really interesting. Maybe when we finish at the end, we can comment a little bit more, but I'm sorry.
Yeah, good. Maybe I will only say that we had also surveys on. Thank you.
Thank you very much. Thank you, both of you.
Very successful. Thank you.
Mm-hmm. Thank you very much. Let's move to our next speaker, who is Dr. Mariana Jakova. She's Deputy Director and International Health Lead of the WHO Collaborating Center at Public Health Wales, and she will be sharing with us health equity and health system strengthening.
Thanks a lot, Sarah.
Thanks, Mariana. Thank you.
Hi, thank you, and a pleasure. Thank you for the invitation to share our experience in Wales with you. I'm just hopefully share my screen, and this will hopefully work. Right. And you let me know if you see the things you should see.
Yes, we do. Thank you.
Right. Okay. Brilliant. I don't know why is this. Right. So I'll try to be very quick, as I know we're limited in time. I've mentioned yesterday, so it's just a bit of information about Wales. For those who don't know, Wales is one of the 4 nations in the UK, so it's quite an autonomous, and in some ways, particularly around the health and care and the social care, independent is a strong word, but let's say autonomous as part of the UK. So we can have our specific legislation and strategies and policies. However, in a lot of areas which are actually important for public health, for example, taxation and other areas, then we are not, of course, autonomous. So we're depending on policies and strategies and legislation, which is UK-wide. And this also includes some aspects of public health and health and care as well. Particularly around the COVID response. Sorry. Are the slides moving, Sarah, just to make sure that you're...
Yes.
Oh, good. Right. So, particularly around the COVID response, just a bit of a note that we have been aligning necessarily, of course, with the UK, but also across with ECDC and WHO on a European level, but also on a global level. So all the response have been pretty, and recovery now measures and different type of non-pharmaceutical measures pretty much aligned with what has been happening internationally and across the UK. So we've developed a different, particularly as Public Health Wales, Public Health Wales is the National Public Health Institute for Wales. We have developed a number of work streams which have been informing and supporting the COVID response and recovery. And I'll particularly focus, of course, around Welsh Health Equity Status Report Initiative and the Health Equity Solutions Platform we're developing, which has been aligned to again serve the needs of the public health system and Welsh Government during the response. We did have other streams around international horizon scanning, a public engagement survey, which was a weekly survey from the public perceptions of not only the pandemic, but also the measures, health impact assessments, and so on. I've shown this yesterday, however, if you've attended the first session. So the work around the Welsh Health Equity Status Report Initiative has been grounded into a memorandum of understanding between Welsh Government and WHO Regional Office for Europe, which was signed last year. And it also replicates a WHO European initiative, which is the European Health Equity Status Report Initiative, which was launched in 2019. So Wales, together with Italy and Slovenia, are the first 3 countries or nations, and Wales is, of course, a region in this network, to apply and implement its own, establish its own initiative, focusing on health equity and sustainable investment for well-being, leaving no one behind. This was done, we have started this work before COVID. However, during COVID, we, as I mentioned, we have realigned and we've refocused all of our capacity and resources. A lot of our teams, or all of our teams, have been also reprioritized and took part into the direct health protection response. But some of the team actually worked and looked into the wider impacts of the pandemic, the impact on employment, on early years with all the school closures, the impacts on inequalities and exposing new vulnerabilities. So as a result of that, our first Westbury report actually focused on the health equity and wider impacts of COVID. In terms of methodology, it combines both national and international evidence as much as was available, but it also has data from our public engagement survey, so the public perceptions, data from administrative and Welsh Government sources. It has some economic modelling and also takes stock and reflects the policy responses. And you might have heard there have been some major policy response across the UK and within Wales to try and mitigate some of the harmful impacts of the pandemic, particularly on the economy and employment. So not to go into details, and you can have, I'm happy to share the link to the report in our chat, I'll do that. These are very briefly our key messages. So we have a few overarching key messages highlighting the key population groups affected in Wales: children and young people, for example, minority ethnic groups, especially from Black and Asian origin, people living at risk or in deprivation and poverty, people not only unemployed, but people living in insecure, low income, informal and low qualification employment. And these are actually especially women, and then marginalized and socially excluded, such as homeless and asylum seekers and refugees, as well as disabled people as well. So we have some specific key messages around the different wider determinants of health. I forgot to mention that, and you might know, whoever is around in this session, that the European history and following from that the Welsh Westry has been structuring the wider determinants into 5 essential conditions, which we've used to as a framework, as an obviously innovative WHO framework to frame our report findings and as well, and analysis as well. So largely as a sort of an overall conclusions, we also took a positive sort of approach, saying that this pandemic provides a window of opportunity, and returning to the status quo before the pandemic is not enough. So obviously we need to rebuild back better, as is a famous, again, a sort of a common saying, and also preparing better for the next pandemic is not enough. And one of the key messages coming out is, again, if we had an underlying healthier population, actually there wouldn't have been that much issues with severe disease and so such high mortality rates. So we do need, obviously, to focus on our improving our population health and well-being, and making our settings, whether they are local, local authorities, local level cities, or regions, are more healthier places for our communities and families.
Sorry, Mariana. We need to finish.
The last item I'll just highlight is, on the basis of this, we're developing a health equity solutions platform, which we're just progressing, focusing on health equity and prevention, with a major stakeholder engagement across Wales. So hopefully we'll be able to launch this next year, and we'll keep you posted with this development. So this is my last slide. Thank you very much, and I'll stop sharing as well.
Thank you very much, Mariana. And thank you very much for all these experiences and inspiring thoughts and challenges, and how to do things in this situation. And we started with the question about which are the lessons learned and what could be continued, strengthening in the future. And I would like to ask Andre if he would like to comment. And then please feel free to use the chat.
Well, thank you very much, Sarah. Thank you for your support, for your work. I think that today many people were talking about the importance of working with the vulnerable group. It's important to provide them access to healthcare services and to vaccination. Well, I suggest that maybe right now we'll look at the chat, at the questions that we received, and then we'll be drawing conclusions after that.
Thank you very much. We have a couple of questions. Some of them have been answered already, and we have another ones. For example, one question is about what is the vaccination rate in Sweden, but already it's answered in the chat. It's about 80%. And then it's mentioned that, of course, there are regional differences, but also local geographical differences. And I would like to ask you in 1 minute about those differences. What do you think could be the main reasons for that? If our colleagues from Sweden could answer that, please.
Yeah. Okay.
You can start, Tina.
Okay. No, I mean, if we look in our larger cities, we can see differences from different parts of the cities in vaccination rates, and we know that is very linked to the demographic challenges that we know socially and primarily socially. So I guess that's also connected to language, trust in authorities, and different factors that we mentioned in our presentation. Salam, would you like to?
Yeah, but also it's about how well informed you are and where your location is in the region. Because if you are in a main or larger city, maybe you have different options where you can get vaccinated or you can get your information from. But in the smaller cities or in municipalities that are not many from these groups from, then maybe it's not like offered in the same way as it is in the larger cities. I just wanted to clarify the rate number. It's from the age of 16 plus. So it's, yeah.
Okay, thank you. Thank you very much. There is another question, very interesting. I think it was at the same time of Piro's presentation. It's about, is refugee vaccination important for you? Piros, would you like to add something on that?
Yes, of course, it's important. As I said, if you want to have universal access, the more marginalized groups have to have specific procedures and attention to pay to them. And so it's very important because of, as I said in the introduction, those groups of population have higher risk of acquiring the infection and are less likely to get vaccinated. So something specific has to be done. And if I can take the advantage just to add one reflection to the discussion about the terminology we use about vulnerable groups, or which is I don't use this term usually because I think it's quite paternalistic to say vulnerable. You see, I myself, I have a family background, immigrants, refugees, and nobody of them is vulnerable. They are very resilient. And working with refugees, I see very, very resilient people, not vulnerable. That I think our healthcare system, our health is vulnerable because we have the objective of universal healthcare, and we are failing this. So we as a health system are vulnerable, not these groups. So, you know, it's a kind of paternalistic. Imagine not to talk about refugees because usually in this kind of settings, there are no, in the audience, there are no refugees. And so nobody replies. But when let's talk about women and gender equity. What would you say if you talk about, oh, women are so vulnerable, they need some help from us? It's not, you know, there you see the perhaps what I mean. I know it's a well-intended use to do it, but perhaps it can have to have a thought on this can be useful, I think, for all of us. Thank you.
Thank you very much. Clara first, and then Salam. Yes, I'm going to close the window because I'm in the hospital and the helicopter is coming with some patients. Sorry about that. Just 1 second.
I thank you so much to the last speaker. I think that was a wonderful point. We really should stop using that term vulnerable, because it creates vulnerability itself. While when naming, when putting the etiquette, yeah, it really creates vulnerability. Probably we should just use the names of as they are. That was really a very good point. Thank you.
Thank you very much. Salam?
Yes, I also wanted to join in that really good point, and that was also the main discussion for us within our organization, that we also looked at our system, because the system and the approach that we had, that when we started the discussion about how to vaccinate, was that we made a small approach that didn't fit all, and that was really a hard task to do, because if you want to take a system to take care of everyone that are in a country, you should really fit a system that is applied to everyone, and not excluding people. So that was like the main point that we took with us from this work, that our systems are not applied to everyone.
Thank you very much. I think there is a great debate going on about how to use vulnerable or marginalized, because it can be stigmatizing for people. The last minute will go to Mariana, because she raised her hand. Mariana, please.
Just to add to the conversation, which I very much agree, Piers, this is a very good point, and we do, I feel, artificially in some ways, obviously marginalize or make groups which are not vulnerable. Having said that, we do feel, and what we've seen obviously in Wales, is that COVID has exposed some of these, whether you call it vulnerability, or has additionally, let's say, marginalized or excluded maybe, or people have remained, let's say, or maybe just highlighted this maybe exclusion, which is not that visible. Normally, we know as public health professionals, but I think a lot of other people don't realize, well, people don't fit necessarily into the healthcare system or into the social system, and they now with COVID, both the economic crisis has actually shown this, that people can actually fall through the sort of net of sometimes of health and social care. So just highlighting this, and this is the sort of the opportunity, I suppose, because COVID has, as disastrous as it has been, has actually highlighted this inequalities, really, we can call it, across society.
Yes, thank you very much. I'm sorry, we have to stop here, but I'd like to thank you very much, all the participants. Thank you very much for sharing your experiences. Thank you, Andrei, for co-moderating the session with me, and we hope to see you in the next session. Thank you very much to all of you. Thank you.
Thank you, Sarah, for sharing. Thank you.
Bye.
You all. Bye.
Спасибо всем. Хочу еще раз напомнить, что нужно будет сейчас
Thank you very much. And a quick reminder, you have to leave the meeting now and use the link that you had initially to be back in 5 minutes for the end of the plenary session. Thank you.